Kia ora, welcome to this session, and what we're talking about is respiratory assessment and the use of respiratory status assessment tools as part of the toolbox that we use as paramedics in terms of either determining patient severity or pushing towards some diagnostic decision making. So let's crack on and have a look at what these slides are going to cover. First thing I wanted to have a look at was a couple of terms, and these are respiratory distress and respiratory failure. And when we talk about distress or respiratory distress, we're talking about an observable collection of signs and symptoms that indicate an issue with somebody's breathing. For the most part, the signs of distress may well be compensatory mechanisms, and they'll have been activated by the sympathetic nervous system due to some underlying issues such as low oxygen levels perhaps, or perhaps there's been some asthma and an increased resistances in the airway. So typically this will initiate an increase in respiratory rate and the work of breathing, and might appear very similar to what hyperventilation could look like. Now, the goal of these compensatory mechanisms is to increase the minute volume of air, the amount of air that passes in and out of the lung over a 60-second period. Now, often these compensatory mechanisms will be able to maintain oxygenation and ventilation values within the normal range. However, in the presence of more severe pathology, it's definitely possible that the compensatory mechanisms won't be sufficient to be able to maintain these values. And if they do fail, the outcome is going to include respiratory failure. So the difference between distress and failure, distress being these observable signs, but failure itself, or respiratory failure, is going to be defined by a derangement in the blood gas values, that is, the values of oxygen and the values of carbon dioxide. As a rough guideline, failure is said to have occurred when the partial pressure of oxygen in the arterial blood supply falls below 60 millimeters of mercury, and or the partial pressure of carbon dioxide rises above 50. And to put these figures into perspective, the normal level of oxygen in the blood supply sits around 100 millimeters of mercury. So to fall to 60 is quite a large percentage fall. And if it does fall to 60, quite often that's when we're looking at saturations in that 93 to 94% range. And an EtCO2 over 50, well, normally it's 35. So again, we're looking at a pretty large increase. Another rough guide in the way we define respiratory failure is where we observe oxygen levels are falling or carbon dioxide levels are rising despite the fact that the patient's been given treatment. So this is what we'd call hypoxia or hypercarbia, that's refractory to treatment, and again is indicative of respiratory failure. Finally, in the presence of respiratory distress or failure, and we see a change in cognition or a change in the level of consciousness, it's not going to be a compensatory mechanism. We're looking at a very severe indication of outright respiratory failure. I think it's important to realise that people can have respiratory failure without necessarily showing lots of signs of distress per se. If we're to acknowledge that, it brings us to the importance of the respiratory status assessment tool and the number of parameters that it's going to examine. Now, without this broader approach to respiratory status assessment, it might be possible to miss signs of overt failure in the absence of distress, or to underestimate the level of distress that someone may be in. There are a number of parameters that we can use to assess the respiratory system, and I've broken this down into three basic groups. One's to look at the vital signs that we would use as part of the status assessment, some of the pulmonary function things that we can measure, and thirdly, we can have a look at the things we can take from clinical examination techniques. But first, let's look at the vital sign parameters. In the setting of respiratory distress or failure, tachycardia is most likely going to be a compensatory mechanism. Now, tachycardia can be due to an autonomic response to hypoxia, to poor perfusion, to pain, fear, or anxiety. If we see a bradycardia in the setting of respiratory distress or failure, this can be an equally, if not more, worrying sign. and it may be related to the cause of the hypoventilation. Now, examples would include inappropriate or accidental sedation with drugs or other forms of toxin. Now, respiratory rate is a very sensitive sign, and like tachycardia, tachypnea is more likely to be a compensatory mechanism that's there to increase the minute volume. And it's significantly less to be the prime cause for the failure. Again, hypercarbia, hypoxia, pain, anxiety, and fear could also promote a tachypnea. Low respiratory rates are more likely to contribute directly to respiratory failure. As the minute volume falls, the amount of air available for exchange is also going to fall. Once respiratory rates fall below 6 a minute and there's no compensatory increase in volume, both oxygen level and carbon dioxide is going to be reduced. And these reductions are going to lead to hypoxia and hypercarbia respectively. And when we look at the skin, often we're looking for cyanosis, and in particular we're looking for central cyanosis. This is a really severe and a late sign of hypoxemia. It's an outward sign of respiratory failure, and it will occur when the partial pressure of oxygen falls below 50 millimeters of mercury, and this would equate to an SpO2, that is our oxygen saturation, being in the low 80% range. Next, we're going to have a look at some of the pulmonary values that may be useful in terms of respiratory assessment. And I appreciate that spirometry is not very common to be used in ambulances anywhere in the world. And many of the functions that spirometry measure are things such as an expiratory volume or the tidal volume or the vital capacity, etc., tend to have a predictive value when we're measuring the effect of pulmonary disease, and they have very limited functions in emergency situations. However, there is one function that can provide some very valuable information, and the one that we seek to use is the forced expiratory volume, which is sometimes called an FEV1, or the element that we use is known as the peak expiratory flow volume. And what this is a timed event. So as much as we want to know about the volume that someone can produce with this test, we are acknowledging that the test is done over a very, very short period of time. And what we're trying to measure with this is the person's physiological reserve, the amount of capacity they have to breathe at this particular time. So rather than being predictive, this function is going to give us some objective information about these lung volumes and the ones that are currently available to the patient. Now, we won't go into this any more deeply, but it doesn't take too much imagination to work out that a falling peak expiratory flow volume, that is the amount of air someone can huff out at once, is going to equate to a falling lung capacity. It's particularly valuable when we're dealing with patients that are suffering from asthmatic or other bronchoconstrictive episodes, as it provides this objective reading of how much physiological reserve, if any, remains there for the patient. Now, values below 50% of the expected norm indicate a severe reduction in this physiological reserve, and it's pretty indicative that respiratory failure, if it hasn't already occurred, is about to. In the absence of a peak expiratory flow meter, a valuable piece of information is knowing that the number of words someone can speak with a single breath correlates very closely to what their peak expiratory flow volume is. In 1998, Curry et al. Published a study that examined the relationship between words per breath, or what he called speaking time, and the peak expiratory flow volumes for a group of asthmatics that they were looking at the time. The correlation was really, really evident, and it was really, really reliable. Peak expiratory flow volumes are somewhat dependent on gender, age, and the physical size of the patient. As a general rule of thumb, you'd expect an adult male to be blowing somewhere between 500 and 600 litres per minute on this particular test. And at the same time, they're obviously going to be capable of speaking long sentences without having to take a breath or showing any signs of distress. 3 words per breath, it's unlikely that the peak flow will be any greater than 50% of what the expected norm for that patient is, and thus become highly indicative of a patient that's not only in distress, but likely to have respiratory failure. Just going to move on to pulse oximetry, and one of the previous slides covered oxygen saturation values, and from that we should realise that hypoxia is established once oxygen saturations fall before 94%. So again, we have this incredibly reliable correlation for an objective reading and respiratory failure. Likewise, we're able to monitor CO2 levels with the use of a LifePak 15 or a core pulse monitor unit. Now, readings between 35 and 45 millimeters of mercury are considered to be sustainable. In fact, 35 is pretty close to normal. But as previously discussed, levels that rise above 50 millimeters of mercury indicate respiratory failure, and the most likely cause for this is going to be hypoventilation. Now is probably a good time for a break, so we're going to end this section here. In the second part of this presentation, we'll go on to discuss the clinical examination skills that are used as part of the respiratory status assessment. Until then, ka kite.